Alright, in this video we will be discussing about neurologic causes of weakness and paralysis. It is next video in continuation with the symptomatology of neurological disorders. Neurologic causes of weakness and paralysis are basically this is basically a symptom or a complaint with which a patient arrives in the OPD, right? It is now the task of a doctor to delineate the causes of weakness, differentiate between weakness and other similar complaints, and what is paralysis, what is rigidity, and what is the distribution of weakness. That is all what is required uh, in the diagnosis of cause of weakness. Neurologic causes of weakness and paralysis, these are required to diagnose a patient on bedside. When you examine a patient, at that time you will require this knowledge. Otherwise this is not a separate entity or not a separate neurologic disorder in itself. It is not a single entity. Basically it is basically a symptom which can be found in multiple entities. So it is very important as far as integration of clinical knowledge of neurology is concerned. So starting with the definitions and the terminologies. Normal motor function involves integrated muscle activity that is modulated by the activity of the cerebral cortex, basal ganglia, cerebellum, red nucleus, brainstem reticular formation, lateral vestibular nucleus, and spinal cord. Right? Our motor function involves many areas of brain and their proper and coordinated functioning in order for our proper motor function to occur, right? Now coming on to a few terminologies which are very important, we must know these terminologies. They say weakness is a reduction in the power. This is the main term which is the concern of today's lecture. We have to understand what is weakness. Weakness is a reduction in the power that can be exerted by one or more muscles. It must be distinguished from increased fatigability. It must be distinguished from articular stiffness. It must be distinguished from proprioceptive sensory loss. It must be differentiated from bradykinesia, and it must be differentiated from apraxia, right? So at least what I can see in this slide is I can see 1, 2, 3, 4 and 5 differentials of weakness. I mean, I mean these 5 differential can present as weakness. Patient with these complaints can present as weakness. Fatigability is basically seen in myasthenia gravis, in which on repetitive muscle contraction, the subsequent muscle contractions are weak. The patient feel weakness on repetitive use of a muscle. For example, if I contract my upper limb, contract my arm, uh, for example, say I contract my arm for 5 to 10 times, and 11th 12th time I will feel intense weakness as if my arm is paralyzed, and it is seen in myasthenia gravis, right? It is fatigability and it is not weakness. So we have to differentiate between weakness and fatigability, weakness and articular stiffness similarly, and other proprioceptive sensory loss, bradykinesia and apraxia, etc. So weakness is different and these complaints are different because their causes are different, right? uh, Now, what is paralysis? Weakness is paralysis basically. When you feel weak, it means you are paralyzed to some extent. It means not complete paralysis, but yes, partial or little or very incomplete kind of paralysis is called weakness. Although complete paralysis is also a kind of weakness, but it has zero power, right? It is patient will tell that I am weak, but when you examine, it is he or she is actually he is paralyzed, which happens in stroke. So coming on to paralysis, we use the suffix plegia, and It indicates weakness so severe that a muscle cannot be contracted at all. But paralysis is a less severe weakness, right? If one is more severe weakness and other is less severe weakness. Now, other important point is distribution of weakness. It is very important. We have to understand the distribution of weakness, because distribution will tell us the cause of weakness. For example, upper motor neurons, involvement of upper motor neurons, particularly in the extensors and abductors of the upper limb and the flexors of the lower limb, right? Upper motor neuron weakness occurs in extensors and abductors of the upper limb. Let me highlight it. Extensors and abductors of the upper limb. It means upper motor neuron weakness. Lower motor neuron weakness means it will it will it will paralyze the muscle supplied by the affected structure, right? The distribution of upper and lower motor is completely different, right? Myopathic weakness is usually proximal muscle weakness, and neuromuscular transmission has no specific pattern. Very important. Means neuromuscular junction disorders like diseases like myasthenia gravis will have no specific pattern of involvement. So pattern of involvement is different in upper motor, lower motor, myopathic and neuromuscular. Now coming on to the tone. Tone means the resistance of a muscle to passive stretch. Very important to understand. Remember it by heart. Increased tone may be of several types: spasticity and rigidity. Spasticity is known as clasp knife phenomena sometimes. Otherwise, spasticity is increase in tone associated with disease of the upper motor neurons. It is velocity dependent. Every word in this definition is important. It has a sudden release after reaching a maximum and predominantly affects the anti-gravity muscles, upper limb flexors and lower limb extensors, right? Very important. Rigidity, on the other hand, is hypertonia, which is present throughout the range of motion. It is known as lead pipe or plastic rigidity. Sometimes it is called as cogwheel quality, means depending on the depending on the character of rigidity. It is enhanced by voluntary movement of the contralateral limb. I mean, reinforcement is present. Reinforcement will uh, enhance the cogwheel quality. Rigidity occurs when certain extrapyramidal disorders such as Parkinson disease is present. Right? Rigidity is associated with Parkinson's disease, and spasticity is associated with upper motor neuron lesions. That is all you have to remember. And spasticity and rigidity are read in tone. Right? Now coming on to the next slide. Paratonia. Paratonia is increased tone that varies irregularly in a manner seemingly related to the degree of relaxation. It is present throughout the range of motion. It is simple English, we have to remember it. But important point is it is present in frontal lobes, and sometimes frontal lobe disorders present as psychiatric illness. So in psychiatric illnesses, paratonia may be found or Gegenhalten. Weakness with decreased tone, which is flaccidity. Flaccidity is a sign of lower motor neuron lesion. Means the limb will be totally flaccid, totally loose. It is lower motor neuron lesion. Now coming on to stretch reflexes. Right, stretch reflexes may hyperreflexia. Hyperreflexia is present in upper motor neuron lesions, and if there is lower motor neuron lesion, these stretch reflexes are depressed. Right, lower motor neuron lesions Stretch reflexes are depressed. Generally preserved in patients with myopathy. Yes, but in advanced disease of myopathy, they may be attenuated. So you need not remember this. For the sake of simplicity, you must remember this only. In disorders of neuromuscular junction, reflex responses may be affected by preceding voluntary activity of affected muscles. Such activity may lead to enhancement of initially depressed reflex in Lamberton and depression of initially normal reflexes in myasthenia gravis. Right. In this slide, it is shown that it is written that how stretch reflexes vary with different diseases. They say if there is myasthenia gravis, stretch reflex will be normal initially and they will be depressed later if you keep on contracting the muscle. Whereas in Lambert-Eaton myasthenic syndrome, LEMS, stretch reflexes are depressed initially and they are enhanced later. Interesting point is that these both entities are neuromuscular junction disorders. These both are neuromuscular junction diseases. One is myasthenia gravis, other is LEMS. But this is the difference in their behavior towards stretch reflexes. Now, the distinction between neuropathy and myopathy is difficult. But if there is distal weakness, it is likely to be neuropathic, and if it is proximal and symmetric weakness, it is myopathic. Important point. Fasciculations are present in neuropathy. Fasciculations. These are seen in lower motor neurons, and lower motor neurons occur in neuropathy. Motor neuropathy means nerve is involved. So this is the uh, what we were discussing. This is all about the stretch reflexes which are seen with weakness. Now what is the pathogenesis? In upper motor neuron weakness, upper motor neurons are involved, right? And you will see spasticity, you will see coarse and slowed movements, you will see dysarthria dysphagia in case of corticobulbar involvement, you will see on EMG that there are diminished maximal discharge frequency. Diminished maximal discharge frequency is present in EMG. This is all to be remembered in UMN weakness pathogenesis. Whereas in LMN weakness, different structures can be involved. Anterior horn cells, axons, right? Brainstem motor nuclei. These can be involved. Either motor nuclei or anterior horn cells or the axons of these neurons, or you can say the peripheral nerves. If these structures are involved, lower motor neuron weakness will occur. Weakness is due to a decrease in the number of muscle fibers that can be activated, right? So we have discussed these 2 points. Now there are two types of motor neurons which supply the muscle. One is gamma motor neuron and other is the alpha motor neuron. Alpha motor neuron will cause the extra spindle part of muscle, means the bulk of the muscle fibers will be supplied by alpha motor neurons, and gamma motor neurons will supply the spindle. Spindle is responsible for stretch reflex, or these are responsible for tone. Gamma motor neurons lesion, if gamma motor neurons are involved, it will decrease the muscle tone and it will attenuate the stretch reflex. If alpha motor neuron is involved, there will be decrease in the number of muscle fibers that can be activated, right? So these two kind of motor neurons, they will cause the difference in the weakness. Absent stretch reflex means spindle afferent fiber is involved. When motor unit is diseased, like in anterior horn cell disease, it may discharge spontaneously producing fasciculations. Very important. Fasciculation means lower motor neurons, element lesion. Neuromuscular junction will produce variable degree and variable distribution of weakness. For example, myasthenia gravis. Sustained or repeat contractions of affected muscle decline in strength despite continuing effort. Right. So this is all about the neuromuscular junction weakness. Another is myopathy. Myopathy is produced by a decrease in the number of contractile force of muscle fibers activated within motor units. Myopathy means the muscle is not. Muscle itself is weak. Everything else is normal. Brain is normal, spinal cord is normal, anterior horn cell is normal, peripheral motor nerve is normal. But the muscle fiber or the muscle cell itself is defective. Why? Because of myopathy. Means the cell is involved. There is certain protein in the cell which is involved. There is certain drug which is causing that cell to get damaged. There is autoimmune disease which is damaging that muscle cell. So if the muscle cell, the last part of the motor system is defective, again it will cause weakness, and that weakness is called as myopathic weakness. We have already read that myopathic weakness is proximal and symmetric. Let us see where is it written. Okay, I will write. It is proximal and symmetric weakness. Right. Inflammatory myopathy, myopathy with muscle fiber necrosis, like muscular dystrophies. Right. uh, on EMG, size of motor unit action potential is decreased and motor units must be recruited more rapidly. Right. Then myopathy, this is different, a little difficult, to understand, but we will read the last line. These myopathies may not affect the size of individual motor unit action potentials and are detected by a discrepancy between the electrical activity and force of muscle. This is what we see on EMG. In EMG, we will observe that the electrical activity is normal, but force of the contractional force of muscle generated is weak. Right. So this discrepancy is diagnostic of myopathic weakness, and it is seen on EMG, electromyography. Psychogenic weakness means there is no organic basis, it is functional. Right. The patient is able to do his household or her household chores very easily, but when she presents to the OPD, she will say that I am weak. Right. So there is discrepancy between the patient's daily activities, between the patient's ability to do daily activities and the presentation of the patient to the OPD. Right. She will go to the home, she will go back to the home, and she will become normal. She will present to you with weakness. This is called psychogenic weakness. Now, distribution of weakness is also important because it will help us understanding the cause of weakness. For example, if there is hemiparesis, means one half of the body is involved. It is suggestive of stroke. If paraparesis is involved, means either upper limb or lower limbs. Either upper or lower limbs. Either upper or lower limbs are paralyzed. This is seen in spinal cord lesions many a times. Quadriparesis or generalized weakness. Quadriparesis is also seen in spinal cord lesions. Monoparesis means one limb is involved, and it is basically involved in plexopathies. For example, my brachial plexus is involved. It is known as plexopathy. Plexopathy can cause monoparesis. Proximal and symmetrical weakness we have just read, it is seen in myopathy. Distal and asymmetric weakness is seen in upper motor neuron lesions. Weakness in restricted distribution. For example, a single motor nerve is involved. It will cause it happens in mononeuropathy. And what are the causes of mononeuropathy? It is vasculitis many a times. It is vasculitis. Uh, it can be diabetic neuropathy, or it can be traumatic. Right. In this case, a single nerve will be involved, and all the muscles supplied by that single nerve will be involved, and it will cause weakness. Right. There will be a certain restricted distribution of weakness, and which is suggestive of a single neuropathy, mononeuropathy, and we can understand the underlying cause, which can be vasculitis, diabetic neuropathy, or traumatic, depending on the history of the patient. Right. So this is all about the neurological causes of weakness and paralysis. uh, I believe you have read a little. I believe you have learned a little from this video, and mm, thank you for your patient listening. I will be coming up with another video soon. Thank you.